Hello everyone. In this video, we will talk about antihistaminics. To understand the action of antihistaminics, that is the drugs which oppose the action of histamines, we should first understand what are the actions of histamines. So it will be easy for us to understand antihistaminics. So what is this histamine? Histamine is the name given to a tissue amine, that is the hist is for tissue and amine, that is present in mast cells, especially in skin, gastric mucosa, intestinal mucosa, lungs, liver and placenta. So if you see these tissues, particularly skin, gastric mucosa, intestinal mucosa and lungs, these form the site of entry of foreign substance. And histamine is one chemical which is released in response to allergen. So these form the site of entry of that allergen. Now this histamine, as I told, mostly it is present in mast cells, but there is non-mast cell histamine as well, which is present in neurons. So this mast cells, these are present in the linings of these tissues, which I already told, and this mast cell histamine has a slow turnover. That means it is not degraded very fast since it is stored in granules. On the other hand, the one which is released from the neurons, it is released and then it is degraded fast. So that has a fast turnover. So this histamine is synthesized from an amino acid, that is histidine, by the action of an enzyme decarboxylase. So after synthesis from histidine, histamine enters into the mast cell granule. So this lining is showing the mast cell and these are the granules of the mast cell where histamine is stored in combination with heparin. Actually this histamine is positively charged, so it combines with a negatively charged substance, for example heparin, and it is stored in these granules. And when the stimulus comes for the fusion of these granules to the membranes, this histamine is released in combination with heparin, but on release, because this heparin is negatively charged, this histamine is exchanged by another ion, that is a sodium ion. So now this negatively charged heparin binds with sodium ion, again positively charged, and the positively charged histamine is released in the blood. So what affects this fusion of granules to the membrane and hence causing histamine release? So here again this is a schematic diagram showing mast cells, and what happens that due to the exposure of the antigen, the allergen, there is production of these IgE antibodies. Now these IgE antibodies bind to this mast cell membrane. On the mast cell membrane there is a receptor for binding the IgE antibody Fc region. Actually, any antibody, if you see, they have an antigen binding region. So here it is antigen binding fragment, A for antigen, B for binding, F for fragment. And the other side is the Fc component, which is responsible for the biological properties of the antibodies. So this region of the antibody binds with the Fc receptor, which is present on the mast cell membrane. Now, in the second exposure to the antigen, so the first exposure is causing the binding of the antibody to the mast cell membrane, but if there is second exposure to the antigen, now this antigen binds with the FAB fragment, the antigen binding region of the IgE antibody, and this causes activation of this receptor. So this receptor is tyrosine protein kinase receptor, and on activation it leads to activation of the enzyme phospholipase C. And just like any other second messenger system which we see with phospholipase C, what happens, this phospholipase C causes breakdown of phosphatidyl inositol phosphate, a lipid which is present on the membrane, to IP3 and DAG. Inositol triphosphate, that is IP3, binds to its receptors on the mitochondria and releases calcium. So ultimately there is increase in the calcium concentration within the mast cells, and calcium is responsible for the fusion of these mast cells granules to the membrane, thus releasing the heparin. Okay, so in summary, basically antigen binding to the IgE antibody ultimately will cause the fusion of the granules, releasing heparin. But there are certain other effectors as well which inhibit the release of these heparin by preventing the fusion of the granules, and that is beta agonists. Beta agonists actually increase CMP and they inhibit the fusion of the vesicles, causing decrease in the release of the heparin. Now, When the heparin is released, it acts on the receptors which are present on various cells. So there are different types of histamine receptors, four types basically: H1, H2, H3 and H4 receptors. In this video, we will be mainly focusing on the H1 receptor. We will little bit touch on H3 and H4 receptor. H2 receptor, we will see that its function is totally different, and the drugs blocking this H2 receptors are used for decreasing the gastric acid production. So I am not going to deal that H2 receptor blockers in this video, because anyways the term antihistaminics is conventionally used for H1 receptor blockers. So first let us see what happens that when these receptors are stimulated. So first is H1 receptor. Remember that H1 receptor directly causes the contraction of the smooth muscle. Okay, H1 receptor directly causes the contraction of the smooth muscle, while H2 receptor, when stimulated, it causes a relaxation of the smooth muscle. So when the histamine binds, this effect is going to take place. So H1 receptor, because it directly causes contraction of the smooth muscle, this smooth muscle is present in various visceral organs, in the blood vessels. So in the blood vessels, this is going to cause vasoconstriction of the large arteries and veins, and it is going to cause bronchoconstriction. Okay, now even though direct action of H1 receptor stimulation is smooth muscle contraction, there is one indirect action. So by indirect action, it causes release of nitric oxide, and nitric oxide, we know that it is a vasodilator. So this causes the vasodilation of the smaller vessels, okay, arterioles, capillaries and veins. So direct stimulation leads to vasoconstriction of large arteries and veins, but the predominant action becomes this indirect action because of the release of nitric oxide, causing vasodilation of arterioles, capillaries and veins. Okay. On the other hand, you see the action of stimulation of histamine type 2 receptor. There is relaxation of the smooth muscle. So yes, there is directly vasodilation of arterioles, capillaries and veins, and there is bronchial relaxation. So if histamine acts on these receptors, what will be the overall effect? Well, there will be vasodilation, because obviously direct stimulation of H2 receptor is also causing vasodilation, and H1 receptor indirectly also is causing vasodilation, but there will be bronchoconstriction. Okay, not bronchial relaxation, there will be bronchoconstriction, because this H1 receptor has higher affinity and it has a dominant effect when compared to that of the H2 receptor. Understanding? So that is causing bronchoconstriction. Then there is also another effect on blood vessels, that is increasing the capillary permeability. So if we see the vessel wall, this is the vessel wall and these are the endothelial cells which I have already drawn. Increased capillary permeability occurs because there is increase in the space between these endothelial cells because of the binding of histamine to H1 receptor, and this increases capillary permeability. Because of this, fluid will leak out of the capillaries, fluid will move out and fluid will accumulate in the interstitial space, and this leads to what? Accumulation of fluid in the interstitial space is edema. Okay, so that is another thing. Now next action of H1 receptor stimulation is in the neurons and in the central nervous system. So histamine also stimulates the nerve endings, and this is responsible for itching. Then in central nervous system, in the brain, it is responsible for wakefulness, because this histamine is released in the brain by tubulomammillary nucleus of the hypothalamus. So this I have dealt in my video on physiology of sleep, that you can have a look. But here just important to focus that tubulomammillary nucleus of the hypothalamus releases histamine causing wakefulness, and histamine also decreases appetite. Okay. It is very important to remember this, because then only we are going to fully understand the action of the antihistaminics which block this H1 receptor. Now, second is this H2 receptor. I told that it is causing the vasodilation and it is also causing bronchial relaxation. But there is another action. Actually, this H2 receptor also increases the secretion of acid and pepsin in stomach. Okay, so release of acid is stimulated by this H2 receptor. That is why these H2 receptor blockers are used for decreasing the production of acid. Okay, and you see that this action is different from all the action which we have discussed till now. Okay, then comes the H3 receptor. H3 receptors are autoreceptors. So this histamine, I told you, it is released from the neurons, right? Here we have discussed it is released from the neurons. Now these neurons also have H3 receptor. So histamine, which is released from these neurons, acts on this H3 receptors, thus causing the decrease of histamine release. So it is more like a negative feedback where histamine itself is decreasing its own release. So that is H3 receptor, which acts as the autoreceptor for decreasing the release of histamine. And finally, H4 receptor. H4 receptors are present in eosinophils, mast cells and basophils, and they are responsible for activating these cells, for causing more chemotaxis of the cells. So activation of H4 receptor basically increases the inflammation. Okay. So this is very important. For now, just remember that H1 receptor stimulation, it causes vasodilation, leads to bronchoconstriction, then increases capillary permeability. It stimulates nerve endings causing itch, and in CNS it is important for maintaining wakefulness, and it also decreases the appetite. Now, histamine injection, if given intradermally, it leads to triple response. Okay, it leads to triple response. That means initially there will be red spot on the skin, there will be wheal, that is fluid exudation will cause edema, that is wheal, and flare will occur due to arterial dilation. Flare is like a spreading redness, that is flare. Okay, so this concept, that is histamine injection intradermally, it is used for testing allergen sensitivity. Actually, you see that antihistaminics, when they will be used, they will block this histamine response, because again this response is due to H1 mainly. I told you that H1 receptor stimulation, it is increasing the capillary permeability. Okay, so that this triple response will be blocked by antihistaminics. Now, when we do allergen testing, what we do is that in one arm we inject the allergen, and in the other arm histamine is given very small dose, and it acts as a positive control that yes, the body is responsive to allergen. That way, that if allergen is there for a person and if he is sensitive, then the body is responsive. If suppose with histamine there is no response, with histamine, that means even if the person is sensitive, even if you give the allergen, there will be no response. So this histamine injection, actually it is acting like a positive control, checking for the body responsiveness. And if a person is on antihistaminics, then this response will be not there. In fact, even if the antihistaminics have been stopped for approximately 1 week, then also we do not get the response. Okay, so this concept is used for testing allergen sensitivity. Then subcutaneous histamine injection leads to flushing again due to capillary dilation, and this leads to increase in heart rate, cardiac output as well. Then intravenous injection of histamine leads to fall in BP. Why? Why can you tell? Well, we have seen that there is vasodilation in the arterioles, venules. Well, arterioles are the major resistance vessels. Okay. So, if arterial dilation is there, then peripheral resistance is going to decrease, and this is going to decrease the blood pressure. Now, in this slide, we have seen that H1 receptor acts by releasing nitric oxide. Now, this is much faster action compared to this H2 action. So, when we give IV histamine and there is fall in BP, actually the early short action is due to H1 receptor stimulation, and still after that there is a slow persistent fall in BP due to the H2 receptor stimulation. Okay, so that was about the actions of the histamine and how histamine is acting through stimulation of various receptors. Now, just a small fact here that all these histamine receptors are G protein coupled receptors, And G protein coupled receptors, they can activate different enzymes depending on the type of the G proteins. So H1 receptors are of GQ type, that is they act by increasing phospholipase C. H2 receptors are of GS type, that is they activate adenyl cyclase and hence they increase CMP. On the other hand, H3 receptors are inhibitory type. Okay, we have seen that they inhibit the fusion of the neurotransmitter vesicles, causing decrease in the release of the histamine. So they are of the inhibitory type and they act by decreasing CMP. Okay, so that was histamine receptors, that was the actions of the histamines. Moving on to now, what will be the pathophysiological role of histamine? Given we have seen all the actions, now we are seeing where all histamine is responsible in various pathophysiology. So first is allergy and inflammation. Very, very important when we talk about antihistaminics. Okay, allergy and inflammation. For example, in conditions like urticaria, where basically we see skin lesions, skin swelling, wheel-like lesions are seen, angioedema, then bronchoconstriction, which is due to allergy, then anaphylactic shock. Here, because of the allergen, the mast cell granules are released and they are going to cause release of the histamine, and it is playing role in all these conditions. However, before we proceed, it is very important to remember that this mast cell granule doesn't only have the histamine. They have other mediators as well, which include the arachidonic acid derivatives like leukotrienes, and there is platelet activating factor as well. And these are the factors which play major role in bronchoconstriction and fall in BP. Okay, please understand. Yes, we have seen that histamine is also causing, but leukotrienes and PAF are also very important for this. So, before we proceed, can you tell me that if we give antihistaminics and the person is having anaphylactic shock or he is having bronchoconstriction, will antihistaminics work? No, they are not going to work because the major action in these conditions is of leukotrienes and PAP. So, we use other drugs for these. But other kinds of allergy, we can use antihistaminics, that we'll see in which conditions it is used. Second is gastric acid secretion, and that we have seen that H2 receptor is involved in this, right? So this is the parietal cell, and here this is sodium potassium ATPase. H2 receptors are present on the basolateral membrane where ECL cells release histamine and which acts on the H2 receptor. Not only that, the gastrin and acetylcholine also stimulate the ECL cells, and this histamine then acts on the H2 receptors. So H2 receptor blockers if you use, because histamine is stimulating this H2 receptor and histamine is also released from gastrin and acetylcholine, H2 receptor blocker will also decrease the effect of these, isn't it? Because they are acting through histamine. So the second is gastric acid secretion. Third is itch and pain. I told you before that it stimulates the sensory nerve endings. Then it is important for maintaining wakefulness and it also decreases the appetite, right? So, what are these antihistaminics? Antihistaminics, conventional antihistaminics which we talk, it is H1 antagonist. Okay, so if I use the term only antihistaminics, I am not using H1 receptor blocker or H2 receptor blocker. If the term is used antihistaminics, it by default means H1 antagonist. Understanding? Now these H1 antagonist or H1 receptor blocker again are of two types. That is, they are first generation, the older drugs, and the second generation antihistaminics. What is the difference between the two? First, both of them have anti-allergic action. Both are having anti-allergic action. We have seen the role of histamine in allergy. It is causing increase in capillary permeability. It is causing vasodilation. So obviously there is more movement of WBCs wherever the capillary permeability is more, right? So that all contributes to allergic action of histamine. And we have seen that how allergen is causing the release of the histamine from the mast cell granules. So histamine, if we block, there will be anti-allergic action. That is one thing. But first generation antihistaminics have other actions as well. Very important. Remember that whenever you use the term first generation antihistaminics, it has both anti-allergic action as well as anticholinergic action. That means it blocks the action of acetylcholine on muscarinic receptors. So it is blocking this M1, M2 and M3 receptors as well. Okay, then this first generation antihistaminics can cross the blood-brain barrier, and that is why they can cause sedation. We have seen that histamine is important for wakefulness. So if the H1 receptor are blocked in the central nervous system, it will cause sedation. Then it is appetite stimulating. Since histamine is causing decrease in the appetite, if you block the action of histamine, there will be stimulation of the appetite. And also because of the anticholinergic action in the CNS, we will see later also we will see that this H1 receptor blockers are used in certain conditions like Parkinsonism and motion sickness. Understand me? So first generation antihistaminics have anti-allergic action, anticholinergic action, and can cross blood-brain barrier. And because of this crossing blood-brain barrier, they have CNS effect. Most important of this sedation, because that is one side effect, and also appetite stimulating and anticholinergic action in CNS as well, right? Plus, one more thing you remember that these H1 antagonists are metabolized by cytochrome P450 enzymes. Okay, so this we have dealt in pharmacokinetics, that how various drugs are metabolized by these enzymes, and certain drugs inhibit these enzymes and other drugs stimulate these enzymes, which can affect the concentration of the drug in blood. So that is very important, because we will see later that how the concentration of some of these drugs increase and it caused very bad side effects, and because of this they were banned as well. Okay. So moving on to the first generation antihistaminics, which have anticholinergic action as well and cross blood-brain barrier. Okay. Now in this first generation antihistaminics, we further classify them as highly sedative, moderately sedative, and mildly sedative. So they are sedative. Why they are sedative? Because they can cross blood-brain barrier. Second generation, they do not cross blood-brain barrier, or very little they cross blood-brain barrier. So they are not sedative. First generation, highly sedative, moderate sedative, mild sedative. In highly sedative, we have 4 drugs: diphenhydramine, dimenhydrinate, promethazine, and hydroxyzine. One thing you remember about promethazine, that is the strongest anticholinergic action. It has the strongest anticholinergic action. Okay. Then moderately sedative, we have phenyramine, cyproheptadine, meclozine, and cenarizine. And mildly sedative, we have chlorpheniramine, dexchlorpheniramine. So this is phenyramine, and its derivatives we have chlorpheniramine and dexchlorpheniramine, then triplodine and clemastine. Okay, so these are the various drugs. Now, when are these drugs used? I told you that both first generation and second generation drugs have anti-allergic action. But when I will talk about the uses of first generation, you see in these uses I have not put allergy. Why? Because we have better drugs for allergy, that is the second generation antihistaminic drugs, which have very less side effects since they do not cross the blood-brain barrier and they do not have anticholinergic action. They are very specific, they target only the histamine receptor. So better to use those drugs for allergy. First generation antihistaminic drugs are used for other uses. One, it is idiopathic pruritus, where we use chlorpheniramine and diphenhydramine. Diphenhydramine is this, right? And chlorpheniramine, which is mildly sedative. And in fact, in idiopathic pruritus, yes, they will block the H1 receptor on the sensory nerve endings. That is one thing. Second thing, because of their sedative effect as well, they are useful. Then we have its use in cough and common cold. Now, we have seen that these first generation antihistaminics have anticholinergic action, and actually most of the uses are because of their anticholinergic action. Okay, so from now onwards, except idiopathic pruritus, what I am going to talk, it is all anticholinergic action. So first is cough and common cold. It decreases rhinorrhea. See, parasympathetic nervous system increases the secretions. So if we block the cholinergic receptors, that is the muscarinic receptors, if we block, then there will be decreased secretions in the nose, that is decreased rhinorrhea. Second thing, because of the sedation, there is a symptomatic relief. The person, if he is sick, so they will sleep, isn't it? So because of the sedation and anticholinergic action, we have certain of these drugs. If you see cough syrups, they will have these drugs, chlorpheniramine, diphenhydramine, they are present in those cough syrups. But directly, if you see that it is not directly affecting the cough as such. Then we have the prophylactic use in motion sickness, and two drugs mainly are used, promethazine and diphenhydramine. In fact, the drug of choice for this is scopolamine, which is anticholinergic, but promethazine can also be given. But you see that this is prophylaxis. Prophylaxis means it has to be given before. That means before the journey, when the motion sickness is that when your journey is very zigzag movement, acceleration, deceleration is there in the journey, then the people feel sick. Okay, they may feel nauseating, vomiting. So prophylaxis means that the drug has to be taken 1 hour before the journey to prevent the motion sickness, and the drug is promethazine and diphenhydramine. Then, due to other anticholinergic actions, the promethazine is used for other uses as well. That is morning sickness in pregnancy. Okay. Then radiation sickness, but again there are other preferred drugs for radiation sickness. That is 5-HT3 antagonists are preferred. Then there is post-operative vomiting. Then we have Parkinsonism. Why Parkinsonism? Well, in Parkinsonism, what happens that actually in brain there is balance between the dopamine and acetylcholine. Okay, Parkinsonism main problem is decrease in the dopamine level. So there is increased activity, relative increased activity compared to dopamine. There is relative increased activity of acetylcholine. So if we block the cholinergic receptors, we will have less action of acetylcholine. So that is why in Parkinsonism, this anticholinergic drugs can be used. Basically, antihistaminics also can be used. That is the promethazine. Then we have acute muscle dystonia. Again, the same concept is there where you block the muscarinic receptor. Then it can also be used as pre-anesthetic medication. So for example, for intubation, we need decrease in the secretions, and also little bit sedation is desirable. Okay, so sedation and anticholinergic action, because of this it can be used as pre-anesthetic medication, right? So all this, as I told you, promethazine is the strongest muscarinic blocker, and all these we can use promethazine. For prophylaxis of motion sickness, we have promethazine and diphenhydramine. Then there is another drug, cinarizine. Cinarizine is can be used for vertigo as well. What is vertigo? Vertigo is a sense of rotation. It is just a perception of rotation because your vestibular system is not getting your motion of the head, your acceleration, deceleration properly. So the person has a feeling of rotation of the world, that is vertigo. Okay, and again, due to both its antihistaminic and anticholinergic action, cinarizine can be used, right? So first generation antihistaminics, what are the uses? First use, idiopathic pruritus because of its antihistaminic action. Rest of the uses you see, mainly it is due to the anticholinergic action. That is common cold, anticholinergic and sedative action. Then prophylaxis in motion sickness and morning sickness, radiation sickness, post-operative vomiting, Parkinsonism and acute muscle dystonia, and as pre-anesthetic medication. Now, what are the side effects of these antihistaminics? That is the first generation antihistaminics. What are the side effects? Those side effects are mainly due to crossing of the blood-brain barrier, so due to CNS effects, and also due to anticholinergic action. So due to CNS effects, obviously sedation will be there. So the person will not be able to concentrate, they will feel very sleepy. In fact, when first generation antihistaminics are given, the person is not able to focus, can't drive properly, and can meet with accidents as well. Okay, and this sedative effect interacts with alcohol. So this sedation effect will increase if the person takes alcohol, and also with the use of other CNS depressants. In fact, because of the sedation effect, these antihistaminics, first generation antihistaminics, are not recommended in children since it impairs learning. Then second side effect is weight gain, because we have seen histamine causes decrease in the appetite. So when we take these drugs, there is increase in the appetite stimulation, and can cause weight gain, especially with cyproheptadine. Okay, and this drug cyproheptadine we will see in the next video on serotonin inhibitors, that is the 5-hydroxytryptamine inhibitors, that this cyproheptadine has that action as well. Other side effects are due to its anticholinergic action. that is dryness of mouth, dryness of respiratory passages, and urinary retention, because parasympathetic nervous system actually increases the secretion and it causes increase in the contraction of the urinary bladder. It also increases the contraction of the intestine. So that urinary retention can occur because this urinary bladder contraction is inhibited. So bladder is not going to contract. Constipation can also occur because intestinal motility will also be inhibited. But remember one thing, that these over the counter cough and cold medicines with the combination of antihistaminics, antitussives, decongestants, they are not given in young children less than 4 years. They are contraindicated. Okay. Moving on to the next part, that is the second generation antihistaminics. So, if you understand first generation antihistaminics, I told you they have antihistaminic action, anticholinergic action, and they cross blood-brain barrier. Second generation antihistaminics do not cross blood-brain barrier. They do not have anticholinergic action, and mainly it is H1 selective action is there. Okay. Plus, some of them may have additional anti-allergic action as well. That means they can decrease the action of the leukotrienes and also the PAP release. So this second generation antihistaminics, remember, are used only for allergy. Very important. Okay, that's what I told you before as well. For example, in case of allergic rhinitis, allergic conjunctivitis, hay fever, urticaria, atopic eczema, contact dermatitis also they can be used, allergic reaction to drugs and foods, symptomatic relief in insect bite, and IV poisoning. IV poisoning, basically IV is a plant, so on touching the plant you can get that reaction. So this is all allergic condition. Basically, if we see type 1 hypersensitivity reaction, type 1 hypersensitivity reaction, where IgE antibody and the allergen interaction with the IgE antibody is important for this type 1 hypersensitivity reaction. But it is not used for angioedema, anaphylactic shock, and seasonal asthma. Seasonal asthma, because bronchoconstriction, I told you that mainly it is the leukotrienes and PAP which is important. So seasonal asthma, they cannot be used. Bronchoconstriction occurs due to other mediators. Anaphylactic shock is a serious condition where we need fast acting drugs. Okay, so epinephrine is preferred for anaphylactic shock. And angioedema also, severe state, antihistaminics will not be very helpful. Oral antihistaminics you take, they are very slow acting. Okay, they can be used as adjuvant drugs, but not the main line of treatment. Okay, so what are these second generation antihistaminics? We have different drugs. One is estomazole terfenadine, but these are not used. These are banned drugs. Why? I told you before that antihistaminics are metabolized by cytochrome P450 enzymes. So, when some people took certain drugs which inhibited these enzymes, actually the concentration of these drugs went high, and these drugs also blocked the delayed rectifier potassium channels, which are important for action potential in heart. So when this was blocked, if you see the action potential in heart is like this, and potassium channels, delayed rectifier potassium channels come to play a role in case of repolarization. So when this is blocked, there is delay in the repolarization, and this prolongs the QT interval. And that is dangerous because it can lead to arrhythmia, and that happened with these drugs. Okay, so these second generation drugs were banned. But now we have better drugs. We have fexofenadine, which is a derivative of terfenadine only, but it undergoes minimal metabolism and there is decrease in the block of potassium channels. But still we have to be careful because it is not safe in long QT syndrome, bradycardia and hypokalemia, again because of the chances of arrhythmia. But it is long acting and only once a day it can be used because the duration of action is 24 hours. Then another long acting drug is loratadine. So remember, loratadine, low for long acting. Again, it is partly metabolized, not fully metabolized by this CYP3A4 enzyme. Then the derivative of loratadine, desloratadine also we have, and these drugs can be used in urticaria and atopic dermatitis. Next we have cetirizine, which is a derivative of hydroxyzine. Hydroxyzine we saw in the first generation antihistaminic, that is in the highly sedative, we saw this hydroxyzine. So cetirizine is a derivative of hydroxyzine. Very important thing about cetirizine is it is not metabolized by CYP3A4 enzyme. In fact, it is not metabolized and it is excreted in urine. Okay. Second, it has additional anti-allergic action, that is inhibiting the action of leukotrienes, and PAF release also it is inhibiting. And it attains higher concentration in skin. So because of this, it is very safe because it is not metabolized. Second, because of additional anti-allergic action, it is having adjuvant use in seasonal asthma. Third, because of attaining higher concentration in skin, it is more effective in case of urticaria and atopic dermatitis because these are skin lesions. Plus, it has increase in volume of the distribution. See, we have seen in our pharmacokinetics video that if volume distribution is more, the drug will be released slowly from that area. And that is why, even though if we see T half in the blood, it is less. But because of the slow release from the skin, the concentration in the blood is going to be maintained, and hence once daily dosing is enough. Okay. So very important of all these actions of the cetirizine. Then levocetirizine we have, which is basically an isomer of cetirizine, which is more potent than cetirizine. That's why it is effective at half dose. Plus cetirizine may have some sedative action, but levocetirizine still lesser sedation is there. Then we have other drugs like azelastine, olopatadine and alcaftadine. So this azelastine also has additional anti-allergic action. Actually, all these three, if we see, they have good topical activity. Azelastine has additional anti-allergic action. Okay, so cetirizine has additional anti-allergic action. Leukotrienes and PAF action it decreases. Azelastine also has additional anti-allergic action, and that is why this azelastine is used as nasal spray. I think I should just put it like this. Alcaftadine is used for allergic conjunctivitis, topical. As I told, all three have good topical activity. So, alcaftadine for allergic conjunctivitis, azelastine and alpatadine as nasal spray, and they can be used in allergic rhinitis, seasonal and perennial allergic rhinitis. So, this you see azelastazine, it is a component of many nasal sprays which are used in allergy. Then we have mesolastine. This is also not metabolized, very important. So two drugs which are not metabolized, you should remember, which is cetirizine and mesolastine. Okay, two drugs not metabolized. So it is very safe. Then we have avastin, which is metabolized by CYP3A4 long QTC interval. So obviously questionable safety. And then we have another drug, rupatadine, which has additional PAF antagonistic activity. So three drugs we have seen which have additional anti-allergic action: cetirizine, azelastine, and rupatadine. And so this rupatadine also is approved for use in allergic rhinitis. So with this, we complete the conventional antihistaminics, that is the H1 receptor blockers. I hope you understood the concepts in this video. And like all pharmacologic videos, the video notes of this video are available for free download from the app. Thanks for watching the video. If you liked it, do press the like button, do share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.